Welcome everyone to our Thursday webinar. My name is Lourdes. I'm Director of Patient Services with the Cholangiocarcinoma Foundation. We are glad that you're here with us today. I want to just wait a few minutes to let everyone get connected to be able to have their audio on so you can hear our guest speaker today. I am happy to introduce Dr. Diane Reedy Lagunes. She is a top New York City oncologist for Memorial Sloan Kettering Cancer Center. She is the creator and host of the breakthrough monthly podcast, Cancer Straight Talk from MSKCC, where she leans in and tackles the subject of cancer head on. She's a noted clinical investigator, has served previously as the president of MSK's medical staff. She currently serves as the vice chair in the Department of Medicine, and we are really happy to have her here today.
Lourdes, thank you so much for having me. It's really an honor to be with you all today. So I was asked to talk about some of the important understandings and what to look for when you're choosing your doc. And in particular, I think for the purposes of today's talk, we're talking about our cancer doc, although I think that we all may have different types of docs that are caring for us for different reasons. So first and foremost, as you heard from Lourdes, I am at MSK. I am a GI oncologist by training. My research interests are in some rare GI cancers called neuroendocrine cancers, but I take care of a lot of patients that have had cholangiocarcinoma, gallbladder, as well as biliary tract cancers. And so for those who are on the call, like you're the reason I do this every day for patients and their loved ones. And I think it's probably the most terrifying diagnosis that patients can get in their lifetime. And I think I find it my responsibility to try to navigate for their patients and their loved ones the storm, if you will. And I think there are lots of different approaches and lots of different journeys. And no one patient and their loved one is ever the same. And trying to tackle that. And I think that's for a number of reasons. So our roles as docs is to try to figure out for that patient what's the right path for them and how do we get there. And there's challenges in that, right? First and foremost, not everybody has the same type of biology of cancer. So under the microscope, we could have 10 patients with cholangiocarcinoma and the cells under the microscope look exactly the same, and they may behave completely differently 10 times. Why that is for various reasons. It may be some of the cancer cells are going to grow faster than others, even though they look the same. Some patients' immune system may be different. Some patients may just have different genes that cause the cancer in the first place. But the reality is we're not all the same. And so although we love to have support groups so that we can kind of empathize with one another and sympathize and understand that you're not going through it alone, it can be overwhelming sometimes because not everybody has the same journey, as I said. And then even importantly, like the same exact type of cancer can be treated in many different ways. And so I think when we're trying to ask this very, very important question of how do I choose the right doctor for me, there's a couple of things that I would advise to at least consider before making that choice. I think for rare diseases in particular, like cholangiocarcinoma, and I'm going to use cholangiocarcinoma, but I think we all sort of care for patients with gallbladder as well as extrahepatic biliary duct cancers as well in this sort of bucket, if you will, of the type of diseases that we try to care for. So sometimes it's how do I get the right surgeon? Sometimes it's how do I get the right medical oncologist? Sometimes it's also how do I get the right liver hepatologist? Because there are associated sometimes liver illnesses or diseases that could have or may not have caused the cancer itself. But that complication of if the liver's not working well, you want to make sure that your hepatologist is also critically on board. And sometimes it's interventional radiologists and or radiation oncologists. So that's a team. How do you pick that doctor? And then the team is so critically important, but can be incredibly overwhelming. So I'm really honored that Lourdes and the team asked me to talk a little bit about this today to sort of try to understand what goes into making that right decision. So a few ideas that I thought I would share with you all today that may or may not resonate with you, but that I would sort of strongly think about at least considering. first and foremost is experience. And when I say experience, the question is, does the doctor do this? And I would say every day, all the time. I take care of patients, like I said, with cholangiocarcinoma, and sometimes that means I have 5 in my clinic in one day. So are you seeing this patient once a year for this type of disease, or are you seeing it, maybe once in the last hour kind of thing? So the experience of the doc that's caring for you, whether it's how many surgeries that they had or how many patients for medical oncology they treat, is critically important. I really want to emphasize the role of the team approach. And if possible, is this a cancer NCI designated cancer center, or can you have an affiliation to that? Why is that important? So as I kind of talked about before, the pathologist, what the cells look like under the microscope, how we define that doc is critically important in making sure we got the right diagnosis. So having a team of the pathologists, of the interventional radiologists that may have to do the biopsy for us, that have then the ability to, once we get the tissue, to do genetic studies, especially in our disease, because this disease is now, thankfully, with so many different types of clinical trials that are on the forefront, but most of them are only in the setting of having certain gene, what we call alterations or mutations. How are you going to know that if you don't have a good center, or at least a doc that knows how to do that genetic testing to get it all done? It doesn't necessarily have to be done at the place, because sometimes there's send outs, but you need a doc that understands the importance of a good pathologist and a good ability to do the right genetics to be able to potentially be considered for clinical trials in the future. So having that experience, not only that the doc has experience for the care of that patient, but that the team surrounding that doc is going to be able to do it in a seamless way that makes it, that much more of an important, outstanding team for you. So that experience is critically important. And then I would say again, do they have access to clinical trials? So for many cancer centers like MSK, the benefit of getting the treatment here, if you're close to us, is that we're able to do the genetics and get the pathologist to tell us exactly what this is. And then that genetic data, if you will, stays in a database. And then if a cancer trial comes up that is opened, we use our own databases or artificial intelligence, if you will, to then send an email and a message to the doc that says, your patient has this mutation, they may be beneficial, they may be able to enroll on this potential beneficial trial. So that's a seamless thing where you and your doc doesn't have to like scour the internet looking for the right trials. So a system, or at least a cancer center that has that opportunity, or it could be a private doc or somewhere in, community where they don't necessarily have that, but they have access to, actually, they know that that genetic data is in a place that you don't have to search hundreds of trials and clinicaltrials.gov to find that. So that kind of experience, if you will, could be incredibly helpful for a patient. And then again, that affiliation doesn't necessarily have to be in a cancer center, but do they have some sort of affiliation to an NCI designated cancer center to then be able to allow us to be considered for clinical trials and or other sort of innovative treatments, including surgeries in the future. So I think those are sort of like, when you look at the qualifications and experience, it's not just the doc, it's the whole team of people that are lifting that doc to do the exceptional care that they deliver, because you have all these people behind them, including nurses, including nurse practitioners, APPs, physical physician assistants, etc. So that's qualifications and experience that I say, again, would be first and foremost. The second, though, and I think it's equally important, is communication, and quite frankly, bedside manner. As I said when I first started, this is probably the scariest diagnosis of a lifetime for many. And having a certainty that your doc is going to be by your side on this journey with you and for you is critically important. You need to be able to understand them, and they need to be able to understand you. And if that doesn't work, we need to at least think about going for a second opinion, to try to understand, like, maybe there's another doc out there that can help me navigate this in a way that works for me. That may be an amazing doc, and their communication and style may be great for 15 people, but just not for you. That's okay. So you should find another doc to help you navigate that. Sometimes that's the right language. I know, understand for some non-English speaking patients, it's very hard to find their native tongue, but there are folks out there for, certain types of languages, English and Spanish and Russian and Mandarin and Cantonese. And so at the very least, access to the right translators if they don't have that, or an understanding that they're going to take the time so that they do translate so that you understand, is so critically important. My team and I are blessed to speak both English and Spanish. And so I have a nurse that also speaks Spanish, and we've done that intentionally so that we are able to care for a lot of Spanish speaking patients, and be able to provide that service so that we're listening in a way that they know. Because again, and you don't necessarily have to speak the language, but we do need, I have, Cantonese speaking patients as well, but I have a responsibility to wait for the translator, ideally in person, so that I can really understand what's bothering them and what they may or may not understand to be clearer. So choosing an oncologist who really knows how to explain things clearly in ways you understand. And again, there's no wrong, there's nothing wrong with, well, they may have been the best doctor in the world, but for me, it just didn't work. That's okay. That's life, and that's where we are. And then again, so the communication in the bedside manner, someone who you feel you're comfortable discussing issues. So I talked earlier that I started this podcast, and one of the reasons why I did that is I really wanted to empower education and educate our patients and their loved ones on all the nuances associated with cancer, but to speak up and to ask the right questions, and then to talk about topics that may be hard to talk about, but that we have to talk about them. So one of the biggest listening podcasts, if you will, or downloads, was on sexual health. Are we having the right conversations for certain patients about that? And can we talk to our docs about that, or do our docs bring that up? And I could say firsthand, like before I had that conversation on the pod, I was doing a lousy job on asking those questions to patients, and some didn't care, and some were like, yeah, that is something that's very, very, very important to me. And so having the bedside manner and comfort that you can discuss your concerns and your issues with the doc can be incredibly important. And obviously feeling respected is also important, because you're building a relationship that, again, is so critically important. The next part, so we talked about quality, for an experience for the doc, the bedside manner, and the communication. And the next piece, actually, that may not come so like obvious, but it should obviously be obvious, is location, location, location. And what I mean by that is convenience. And having a local team is really important. So, you could obviously and understandably, if you're a loved one to somebody with this cancer, you may be like, I will travel the world. And I think we'd all travel the world for anyone that was diagnosed with this terrible disease. But there is a sense of comfort in getting care local, close to your home, so that you can go home and rest and go back and forth, and you're not taking the bus to the plane to the train, or kind of going back and forth on hotels and other things. There may be periods of the journey that could be critically important, like if you found a clinical trial that's right for you and other things. But the reality is, having somewhere convenient can be really, really helpful. So you can say, well, you just told me that I have to find someone with a good relationship and good qualifications and good experience, and I don't have that in wherever I may be. But you could go for a second opinion and get it at an NCI cancer designated center or a major cancer hospital that's close enough to you, so that then part of the care could be dictated, if you will, by them, but then also by your local team. And that happens here all the time. I have patients in almost, I wouldn't say every state, but in many, many states. And because I take care of rare diseases, those local community docs are more than happy to run things by me, get me on my cell phone or on a WhatsApp or whatever, and be able to allow me to help guide that treatment. And so I may not be quarterbacking every play, but I am able to help the community team take care of that patient for as good as they can, care for them. And I think having someone that's smart and reliable and close to home can be critically important to make sure that you get the best care, because things happen, right? Especially for our patients that are on chemos or immunotherapies or other treatments. You may need hydration, you may intravenous, you may need labs, things that are just going to pop up, and you want access to your doc to be able to do that in a timely manner. And getting in a car and traveling 2 hours is just not the best for things. So I think, as best as we can, find someone with a location that is suitable for you can be very, very helpful, and I think very important. And then last but certainly not least is the insurance piece. Financial toxicity is real. For many of our patients, it's so real that they often, we have good data that show that some patients don't even use all the medications that they're supposed to be prescribed because they can't afford it. So do you have a doc that's covered in your plan? Is there transparency on what you do or don't have to pay for? And really thinking about making sure that your team and the care that you're going to get is obviously, hopefully, the best that it can be, but in a cost efficient manner that you're not going to have to worry about all the other financial challenges that may come up if they're out of network, because that could be a huge deal, and like in a terrifying way. I just get so worried for patients, and because our healthcare system is so broken, very often the doc doesn't even know that you may have issues with insurance. And so I may be prescribing a drug and then I find out later that it was X amount of dollars, and so I have to go back and redo it or something like that. But it's not very clear on who may have issues sometimes with certain parts of their insurance or not. So that transparency and being able to talk to your doc and his or her staff about that, and being able to find an insurance that accepts your health insurance plan, and the docs being able to do that is very, very important. Thankfully, there are a lot of online resources. Sometimes there are too many. And so navigating, I always say Dr. Google could be very, very overwhelming at times. I think the good news is that there's a wealth of information out there. The not so good news is it can be a little overwhelming. So I think that the most important ones that I would recommend is sometimes just, you could start with your primary care physician and asking them like, who are the docs that you know that would be reliable for this? But the resources online include, so for example, if you have a localized cancer that you're hoping to get surgically resected, not only can you and should you talk to the surgeon about how many have they done, and what there's, I know it's hard to say, well, what's your success rate? But it's very fair and a very, I think, thoughtful question to say, is this a cancer that you take care of, and how many of these operations do you do a year? That's a really important question for you to empower, yourself, and also to serve as your own advocate or have your loved one ask, if you're a little overwhelmed to ask that. But then there are online resources. The American Surgical Oncology Group actually has online website where you can go and look it up and see how many of your surgeons have done that many cases. And so that's a reliable resource that can be very helpful sometimes for you to just sort of double check if you're or if you're uncomfortable asking. Same thing with medical oncologists. There are lots of different resources, including the American Society of Clinical Oncology, where you can go and search the database of oncologists in your area that specialize in your disease. And in cholangiocarcinoma, and they'll be able to tell you, like, with X mileage of radius, who might be the person to go to. And if too far, then at least going for a second opinion could be critically helpful. And then actually your insurance company can actually be quite helpful in giving the list of providers that then falls in the umbrella of your insurance plan, and getting the experts of for your disease can be very helpful for that as well. So I do think that the right oncologist is something, again, you need to feel comfortable about and trust. But I think that at the same time, you don't want to ever hesitate to say, well, maybe I should get a second opinion. I'm a big believer that at the very least, even if you absolutely love your first oncologist, going for a second opinion, particularly in diseases like cholangiocarcinoma, where it's uncommon, could be really helpful and important, because you just want to make sure that you're doing everything that's right. I always say to my patients and their loved ones, we get one shot at doing this right. We can't, unfortunately, in the world of cancer, make up for mistakes sometimes. I don't mean to scare you with that, but I can't tell you how many times patients say, oh, it's time to go to MSK now because I've run out of all treatment options or this or that. And that's not the right time. The right time is to go early as possible so that we can help navigate the plans. You can still get them with your community doc if that's what you want, or if that's what's best for you. But sometimes it's a little too late, and that we don't want to happen. So I think a couple of different oncologists before making the final decision can be very helpful for everybody, and just making sure that you're formulating a plan. So that's kind of what I had today to talk to you about, the sort of ways that I think is important to look for a doc. Lourdes, I'm happy to answer any questions that everybody has, and or anything that I said about the disease or about anything that you'd like to ask.
Perfect. Thank you so much. If
Sure.
anyone has questions, please enter them into the Q&A or the chat. And if you're online via Facebook and you have a question, you can put them into the comments and we'll make sure to ask them. Um, Nothing yet, but I do have a question for those patients who are in remote locations and maybe the financial piece of travel to for a second opinion is challenging. How would you suggest that they maybe use those tips that you're suggesting in a way that like empowers them to do those tips, you know?
Yeah, that's a great question. So I think that there's different reasons to travel for different sort of stages in this cancer. So like if it's sort of stage 4 where operative attempts is not going to be considered versus a surgical approach. And then we have liver-directed approaches and different things. I think that in general, most insurance companies, I don't want to misspeak, but most insurance companies do allow for a second opinion, particularly at a cancer designated center. So the ability to do that is something that is almost always covered by insurance, and going straight to the insurance company and asking, is this going to be covered? Believe it or not, sometimes even travel is covered for certain insurances and the hotel. So just ask, there's no harm, no foul in asking for that. But I do think that's critically important. There's other foundations as well that sometimes do provide transportation for folks that may not be able to afford the transportation and or hotel. So there are resources out there. So maybe the social work or case managers at your community facility could help you with that if that's something that would be hard to navigate. But I think, thankfully, the other piece that we didn't talk about that I should have is telehealth. So many folks can get a second opinion through telehealth. Now, during pandemic, we could do telehealth anywhere, anytime. Now it's a little bit trickier that in certain states or many states, you can only get the telehealth within your state. But that doesn't mean, so for example, I'm in New York City. If I have a patient that's, 3 hours up north in upstate New York, I could still see them on telehealth. And so we do that a lot. And again, that's in the comfort of your own home. You don't have to necessarily travel for that. And that could be helpful for a second opinion. So I think that could be an additional resource. I think in terms of looking for clinical trials, that's a little trickier because I think trying to navigate that, one, even knowing, is this going to be the right clinical trial for me? And then two, what the lift, if you will, is going to be like, how often am I going to have to travel back and forth? And what does this really look like for me? That's a lot. I always say to be on clinical trials takes an enormous amount of bravery for our patients. It's quite courageous to be on that because it's experimental. It may work, it may not work. It's very helpful for the community and hopefully for the patient. Um, but I think even if you could potentially do that by telehealth, or at least at that first visit, getting a very clear understanding of like, what would this really entail? Because I think that we would all do everything and anything if we knew for sure that these trials were going to be helpful, but many of them aren't. So I think we just have to have our eyes wide open on like what we're doing, why we're doing it, and then make the, sort of calculated decisions on, is this worth the travel? And then if it's financially very high, how do I get the right resources to help me? Because there's a lot out there that could help you with that.
I have a question from someone who is asking about the differences in suggestion or maybe like what they're being told. So if a surgical oncologist says yes to surgery, but the medical oncologist says no, can you explain maybe why something like that would happen and like those differences of opinion that exist within the team?
That's a great question. And I think that's kind of where I was really good question. It goes back to what I was saying before on like the team approach. There's nothing more unsettling of having two respected oncologists, the surgical oncologist, the medical oncologist, give you two different opinions. Like, like, wait, really? I mean, here you are trying to deal with this diagnosis, and now you got two different opinions. I mean, that is a whirlwind and can feel like a hurricane. I think that the eye of the beholder can be very important on, generally speaking, our surgeons first have to ask us or tell us, is it resectable or unresectable? And so when we say that, it's, how close is it to vessels or to nerves or to things? Because we really, in oncology, there's no such thing as getting it almost all out and being a successful surgery. You really need what we call R0 resection, where the whole tumor comes out and all the margins are negative, and no cancer is left behind that we can see. Because we have study after study that shows if we only get 99.9% of it out and there's still a margin left, or there's a little cancer left over, that's not good enough. And so that part of the question is important, on where there may be discrepancies between, the surgeon says it could come out, the medical oncologist says it can't come out. But the second reason probably that can be a little bit confusing is biology. So sometimes, again, I sort of started as saying you had 10 patients with under the microscope, the cancer looks exactly the same, but some of them are behaving a little more aggressively than others. And so how do we know when surgery is the right thing to do right away, or sometimes doing a little bit of what we call upfront chemo, or immunotherapies to sort of make sure? So the pattern of disease is really important. So are there small things in the lung that may or may not be real? And do we want to treat a little bit first? Because again, if there's small little things in the lung, that means we're not surgically taking out 100%. And so we really have to ask the question, are we helping our patients live longer or better by only taking out a piece of the pie? A centimeter of tumor is 1 billion cells, which is a little bit overwhelming. But when you think about that, that means, well, you're like, well, I just have this tiny little thing in the lung, but there's a couple of them, but that means there could be billions of cells in the lung if you have these small nodules. So the pattern of disease can decide, like if the oncologist thinks there's metastatic disease versus, maybe that's the difference, or maybe it's a resectable question. So I'm not really sure. I know I'm not exactly answering the question, but the discrepancy issues of maybe one oncologist saying things versus the other often has to do with the scans. If they think it come out easily, if that's really the only site of disease. And then the last part is it behaving more aggressively, in which case maybe we want to start with some treatment first, because the hardest thing in the world for everybody, doctors, nurses, patients, and loved ones, is going to the operating room and then closing up because we couldn't take it out, or going to the operating room, going through that entire surgery and recovery, and then just weeks later, something pops up again. So we don't want to do that. We're making our best guesses on these things. And so when your medical oncologist is saying, no, I don't think so, they're usually saying that because they're worried that there could be more disease elsewhere. And that's why they don't think it's the right thing to do.
Okay, thank you.
Sure.
Is waiting until your doctor prescribes treatments a reasonable time frame to then seek a second opinion?
Sorry, say that one more time. I was looking at
So
this.
waiting until your doctor prescribes a treatment a reasonable time frame to then seek a second opinion? So
That's a good question. Yeah, look, I think that there's no time that you have to seek a second opinion. You could do it then and waiting. I think that what gets a little scary sometimes is just being able to like set everything up. So I think you could set up the opinion, but I think the question is an important one, because it sort of talks to what can typically happen, which is a lot for a patient, which is to say, you spend hours with the doc, and then the doc says, I need to present you at our tumor board. We'll get back to you next week. And so that's a little bit hard because the doc's not telling you right away what they would recommend. But getting some understanding of what the doctor may or may not think is the right thing to do can be very helpful for that second opinion, and sharing that with them to then get an understanding, like, do you like that idea? And if you do, why? And if you don't, why not? So I think it is helpful once you get to that second opinion to sort of say, well, my doctor said that this would be or at least we're thinking about this. What do you think of that idea? Just can give you a little more information.
okay, I know that we have a couple of questions that are second opinion related also in
Yeah.
terms of timing, and maybe after so many treatments, or even if it's like 2 years into treatment, is second opinion still a valid thing to do even after time has gone by?
Great question. Yeah, I think it is. So, I mean, I think if there's no evidence of disease, like if it was surgically removed, you um after so for our disease, if we can surgically remove it, we offer some sort of adjuvant therapy, and usually that's like within 6 months after the surgery. After that, the incremental benefit of doing much is too low, and so we wouldn't like offer anything additional at a year or two or anything else like that. When there's active disease that hasn't been surgically removed and you've been living in it for 2 years or what have you, often if there's disease progression, I think you absolutely can and should go for a second opinion if your doctor's not quite sure what to do, or if you feel like maybe this is a good time to make sure that we're doing everything right. So I would definitely encourage that. Again, I do think the importance of genetic testing for our disease is pretty important, because you want to make sure that you're getting that. So if you need clinical trials in the future, or if you have certain mutations and amplifications that allow us to use certain therapies that are standard of care, we're doing that, like IDH1 and FGF, which I'm sure you guys have talked about a lot.
Do medical schools promote sales training, in quotes, for student doctors to improve their bedside questioning and manners? Classes in humaneering can go a long way.
Amen. I don't, we definitely have medical school classes that talk about humanism in medicine. And I think that everybody's responsible to take something like that to understand empathy and compassion. I just think that the nuances are, like people in my family say, speak English. When you talk medical jargon, sometimes you don't realize that what you're saying makes no sense to the layperson. And I think that's the part that I don't think medical schools do very well. Like, how do you communicate in English and, in ways that, we recognize how, I mean, our patients are all really smart. It's just, it's a different language sometimes, the jargon that we use. And I'll give you an example of that. The Cures Act, which you may or may not know, the Cures Act is something the federal government mandates that the second a pathology report or a radiology report or mammogram report, whatever it is, comes out, we're required by law to put that up on the patient's portal and give those patients results. And so at one point, you could say, that's great. I want to know everything I need to know. And I think that's very empowering and great, especially when it's all negative and now patients can breathe a sigh of relief. They don't have to wait a week for their doc to get back to them. So there's something very important about that. The problem is that we're not writing them in layman's language. And so it's all in medical jargon. And so I can't tell you the number of calls, frantic calls I get from patients thinking that something that is completely benign is malignant because we didn't say it in normal English. Or now they have active disease that they didn't know that they had, and I didn't get a chance to review it. And we use words and terminology sometimes that could be very terrifying to patients. So, it's sort of like no good deed goes unpunished, but it is an example, like if we were able to, now that it's out there, maybe we need to say it in a way that everybody would understand. But it can get a lot. So I do think that we could do a better job at communicating or educating our I'll say LIPs because nurse practitioners and physician assistants are such a big part of oncology, but doctors, LIPs, and nurses to sort of speak to patients, although our nurses do it a lot better than we do.
Is any particular treatment, from your understanding of it, considered a last resort option, such as like transplant, for example?
Is transplant a last step option?
A last resort, like a type of treatment.
Yeah, look, I think that transplant for cancer has been tested in different types of solid tumors, such as cholangiocarcinoma, such as hepatocellular carcinoma, which is another type of primary liver cancer. There's some work now going on into colon cancer. I think there are definitely studies and in some patients, opportunities to consider that. I think the problem becomes it's all about the right patient and selecting out the right patient to do that. Because when you transplant a liver and now you put in a new liver, as everyone knows, you have to be on immunosuppressive agents. And so the risk is now you're immunosuppressed. And what can often happen is that now it's like the immunosuppression itself can create this inferno, and then the cells that may have left the liver and hide in the bone or sometimes in the blood and in the lymph system can jump right back to the liver. So what we don't want is to, again, have a patient go through such a big transplant and then very quickly thereafter have the cancer come back. And when we say come back, really what we mean, it was there the whole time and now it's just going to start to grow, and sometimes at a faster rate. But transplant has been considered at certain centers, but you have to really be aware of the biology. Like if it's outside the liver, it's a very bad idea to do a transplant because it's just going to start to blow up if you're on those immunosuppressive drugs.
Could an out-of-state doctor call and get suggestions and a second opinion for a patient?
That's a great question. So the answer is it depends. So there's something called compact. So compact was something that the states all decided. So every state, as you probably know, is responsible for medical licensing. And so states were worried that, and now with a lot of different political agendas and views about healthcare, states have decided, no, we're going to do it our way. And we're only going to allow now, since the pandemic has moved on. Well, I mean, it's still here, but that only practicing physicians in my state could take care of my patients. But then the compact came along and said, okay, that's silly. We're all sort of very similar in terms of just the medical licensing, and it would allow our patients to get care, particularly with rare diseases, from docs that may specialize in these diseases that are out of state. So there's like over 40 states that are at least in the compact or applying to be part of the compact. And that will allow physicians to get this license agreement so that you can see patients out of state by telehealth. You could still drive. So, for example, if a patient in Pennsylvania wants to see me, they could drive to Manhattan and I could take care of them. But if they're in Pennsylvania by telehealth, I am not legally allowed to take care of them. So the compact can help for some states, and you could just look it up online in terms of compact, and you could see it's by color if your state is involved in that or if they're going to be involved in that could be a way to understand.
Okay, thank you. How do we find the resources you mentioned to look up oncologists and how many patients they have treated?
So the American Society of Clinical Oncology has that. You could look up on their website on it.
And then if their oncologist is recommending staying close to the academic center near their home rather than going for another opinion outside, what is your, I guess, thoughts on that?
Yeah, look, I think if you find, whether it's online or through word of mouth or by, somebody that you really felt like you really want to go see, and financially you're able to do that, I think you absolutely should. I think the problem becomes, particularly when it comes to clinical trials, of like just the overwhelming nature of it. So if you want to go to MD Anderson in Houston, Texas, and you happen to live in Michigan, like, is that feasible and something that's going to be helpful for everyone? Now, it may be because we have some amazing cholangiocarcinomas docs down there who are good friends of mine. But you want to make sure that it's for the right reasons, and maybe there's something unique about that trial that would be different for you that you would want to do that as opposed to going somewhere a little bit closer that your oncologist has a working relationship with, because there is power in that relationship and being able to take advantage of that and knowing that they're going to take care of you and communicate easily, because it is hard sometimes to find, like, you want to make sure that the oncologist, the cancer center, can communicate back to the community doc in a timely way and in a way that's helpful for everybody.
Okay. For those individuals maybe who have a doctor who they don't, you mentioned like the communication piece and like, being able to feel comfortable with their doctor, but maybe the patient themselves isn't comfortable saying something about, how they're not feeling great with that particular doctor. How would you maybe like suggest or give a tip to those patients on how to like advocate for themselves to then like
Great
move
question.
to find somebody else who maybe they can mesh better with?
Yeah, so almost every clinic or hospital should have what's called a patient rep. So if you're not comfortable actually talking to the doctor about that, asking to talk to the patient rep to see if you could potentially transfer care or that there was something that you were a little bit upset about or you wanted to discuss, their responsibility is that they're supposed to help and advocate for you to see if you could potentially make a switch. And I can tell you here that happens all the time.
Thank
Yeah,
you.
great question.
Um, does a doc have to do something other than be in an eligible state to be accessible via the compact arrangement?
Yes, it's like a 1 or 2 page form that they have to fill out. So the doc does have to apply for it, but the turnaround time is pretty quick. But yes, it is something that the compact allows you to get a medical license in all the states that are part of the compact. So most of the healthcare systems that are in these states that have it, I'm sure are working so that all their oncologists are on there, but I'm not sure that all of them for sure are part of it. That's a great question.
I guess, and following up on the compact, because I'm sure that other patients out there might want to encourage their doctors to participate.
Yeah,
Is that something that a
exactly.
patient can like maybe advocate for others because this community is very close in terms of connecting, like, and mentioning the compact arrangement to their oncologist?
Yeah, I think so. I mean, I think that their local oncologists, though, would be in their state. Really, what we want are the docs that are out of our state to be in it so they can help us um, and take care of us, right? And so that's the part that's a little bit tricky. So, for example, New Jersey just enrolled in the compact, and so if there was somebody, a doc there that was caring for cholangiocarcinoma that we really wanted to see, it would it would be great if we could sort of advocate for those docs to just fill out the cockamamie thing.
Okay. Um, so this individual has wanted to travel and not go back home for their immunotherapy, but they asked if their oncologist if they could get the treatment in another state. There was a no, was the response to that question, saying that they needed to have an oncologist in that location where they were traveling to. Um, is there any particular maybe reason why perhaps that's not permitted?
Yeah, it's the same thing. So at a state level, like your treating oncologist, if I were a treating oncologist in New York and you want to go to Florida, I am not legally allowed to prescribe immunotherapy in Florida. So the way that you could get that immunotherapy is then you would have to set up to see an oncologist in that town or city, wherever you are. And then they could give it. It does get done though. I mean, we definitely do have folks, especially like, for example, snowbirds, that they're here up some northeast and then they go to the south during the winter months and they have docs down there that they transition to, but it's usually for a longer period of time as opposed to just one therapy because that might be a little bit hard. And I don't know, for example, if it's only 1 or 2 therapies, what insurance would allow. And then obviously by state, if your insurance is in the state and only in the state, that gets a little bit tricky too.
Um, those are all the questions specific to choosing a doctor that we've had.
Okay.
If anyone else has any questions specific to this topic, please send them in. But I think that everything that you've shared has been really helpful. I think those are good tips for individuals to have and just to
I'm so
use.
glad. Yeah, I mean, I think that, like I said, this is the time where it could be very hard and overwhelming because you're just, sometimes we go day by day, sometimes it's hour by hour and trying to get through all of it and navigating it can be very hard. Many people thankfully have caregivers and care providers that can play that role, but many people don't. And so trying to sort of figure out what's best for you can be hard, but getting at least more than one opinion is something that I strongly advocate for, particularly in diseases like cholangiocarcinoma, where it's just not so common. And so you want to make sure you're in the right place and that you're getting the right best care for you, and that the ability to communicate and understand what's going on, because you want to be part of your care, right? You want to be vocal and have the, be able to ask the right questions so that you're helping to guide the care in the best way possible for you. And that's hard to do if you don't have good communication. Um, and so, yeah. And so, again, my podcast is called Cancer Straight Talk, if that's something that anyone's interested in doing. And we do have one that's a couple of episodes that's focused on the role of a team approach and really, making sure that in your center, that ideally your surgeons and your medical oncologists and your radiation oncologists are really all collaborating together. And like we said, like the bench runs deep around here where there's just lots of people that we rely on to help us get the right answer so that we can treat the patients in the best available way. So I am blessed because I have all these really smart people that are helping me decide what the best approach is for the patient. It's not just me, it's a team.
Thank you so much. Thank you for sharing this and for speaking to our CCA community. And to everyone who's on, just a friendly reminder that you can also use the ICPR, which is the patient registry, which is powered by Citizen to help collect all your medical records into one location.
Absolutely. And a shout
Um,
out to the other Matt Reedy who was on.
Great. Thank you so much. Thanks,
Thank you.
everyone.
It's really nice to be here with you all. Take care. Have a great spring.
Bye.
Bye bye.